Thank you very much, Dr. Rasindus. I would like to thank the organizing committee, Dr. Fawaz, and the team for this fabulous job. Thank you very much, everyone. So I'll start with my talk. I put a title of From Desperation to Delisting, the Mitral Clip Solution. So let's go with the patient. This is a 33-year-old female, a mother of 5, strong positive history of dilated cardiomyopathy. She presented to the local hospital with decompensated heart failure, investigated and diagnosed as dilated cardiomyopathy with severe mitral regurgitation. She has recurrent admission, 2-digit admission of heart failure. She was referred to our hospital for advanced heart failure therapy and to start the heart transplant workup. Worth to mention that she's blood group O positive. MDT, multidisciplinary team discussion was a plan that the patient should be listed for transplant as she is in the stage heart with stage C and 2D, and with mitral clip or M-tier to elevate the symptoms of heart failure if possible. She was referred to the structural interventional group for M-tier. This is her echo, transthoracic echo, that shows the patient has severe systolic dysfunction and significant mitral regurgitation. That is, I think it's with no doubt that the systolic function is very low. Now, the transesophageal echocardiogram images with the surveillance for the suitability of the mitral clip as follows. This is the length of the septum and to the mitral valve. This is the annulus. The annulus was measured as 3.6 or 3.56. The leaflets, both anterior and posterior leaflets within the acceptable range. And you can appreciate that the severity of the mitral regurgitation. And this is an important sweep in the explain to show that you go from side to side and you go to an A2, B2, and you check where is the maximum jet that you have, and then based on the numbers that you get and the angles of the probe, you can suggest to the intervention to the echocardiographer in the next, if he's not the same person, that you may go to that angle that you will find the jet better, and then after that the grasping view to show you the best site to the 3-chamber view, and you can appreciate that, and here is clear. So this is the 3D of the valve with the 3D color that shows you that the aorta at the top, and then the lateral to medial, lateral, anterior, medial and posterior. And you can see it, it is in the lateral to central of the
Okay, keep the 3D running, Victor, please, if you don't mind. Yes, I think you finished your screening, right, by that?
And that is the finish of my screen.
Okay, so we're moving on. We can use the interactive board with Dr. Anas. Dr. Anas Mirdad is a consultant imaging cardiologist in King Faisal Cardiac Center in Jeddah. So, Dr. Anas, you have seen the case, you've seen the images. Right. Is there any questions or anything before you start? And what is your strategy afterward?
Okay, so as we can all see here, if you actually can go just to the previous slide, just prior to this one. So you can see that the posterior, if there is a version without color, that would be great, but this will do actually just fine. You can see that the posterior leaflet here on the left side is apically restricted, and there's anterior leaflet override, which is typical for functional mitral regurgitation. If you go back to the bicommissural view, please. This will do actually. And you can see here on the top right image that the jet is quite wide, meaning that we have a more semilunar vena contracta, which is again typical for functional mitral regurgitation. I have a couple of questions for Dr. Ahmed here. Just wondering about the baseline mitral valve area and the mean gradient, as well as the posterior leaflet length.
So the mitral valve area, it was 3. Initially it was maybe 3.8 and then 3.6. That's the latest TE prior to our clip.
Okay, and what about the mean gradient?
Mean gradient was 1 or 2, I think, maximum.
1 and 2. And the posterior leaflet length?
Oh, it's in here. So I think it's 13.
All right. So Just as an imaging point, the posterior leaflet length here was measured at 0 degrees, and when you're at 0 degrees, you're actually cutting the valve at an angle. So you could be slightly overestimating the posterior leaflet length. So I generally recommend for the imagers to try to go perpendicular to the valve, which is anywhere between 120 and 150. And then the other thing is that I would recommend measuring the mitral valve area by MPR. So we have a small, kind of a borderline mitral valve area in this case, 3.8 to 3.6. We have an acceptable gradient. The posterior leaflet length here is 1.3. If I were to, definitely the jet is wide, so I would either go with an NTW or an XTW. So this is the initial, I would choose a wider device, number one.
So, Dr. Anas, you're going to say you would have like further imaging in terms of to get the posterior mitral leaflet, number one.
Exactly.
Number two, are you comfortable in the screening to take the area or intraoperatively to take the area? Are you going to depend on the annulus or not?
I generally, what I depend on is the mitral valve area by multiplanar reconstruction before the procedure.
Before the procedure.
So at baseline, yes.
And you're choosing now as a device choice, you're going to go with an Abbott MitraClip.
Yes.
Either NT or NTW?
No, NTW or XTW. So I would go with a wider device, and the mitral valve area is on the smaller side. So if I go with an XTW, I might run into having a higher gradients post-grasping. So my initial choice would be to go with an NTW device, and I would go just in the middle at A2P2. That would be my initial strategy.
Can you show us the 3D again?
Okay.
So I have just a quick comment. As Dr. Anas said, the typical views to measure the posterior leaflet is the 0 degree and the outflow view, which is the 120 or 130. But this is with the assumption the maximum jet is central. So central jet, those are two typical views. But actually now with the new tools and the machines, we use the MPR. Like, for example, this jet is a bit slightly deviated to the lateral side, as we can see here. So here you need to tweak your view to exactly cut where you want to clip. So in this view, look at where exactly the center of the jet. Then you tweak your MPR to the center of the jet, because the typical view is sometimes deceiving.
I agree.
Because it gives you the maximum in the central jet, but in those deviated to the side, sometimes you need a bit of MPR. MPR is the multiplanar, I mean.
Yeah, definitely. I totally agree with this. And if the resolution is helpful, we can get a posterior length on MPR.
So what do you think now about this 3D? What do you think about kind of is it only purely functional? Well, is it only A2P2, or is it a bit like a deviation or something? What do you think? And where can you plan your NTW or NT?
Yeah, so the leaflets are thickened. There could be some, I don't remember if the 2D images showed some degree of calcification. There could be some degenerative changes to the valve. Actually, just looking at the non-color 3D image, I wonder if the just medial to the A2P2, I see more apical restriction. I would confirm that by going to biplane, so 60 degrees, and try to biplane across the valve and look at the morphology on 2D quite carefully. But I wonder if there is more apical restriction to the posterior leaflet, just slightly medial to A2P2.
Okay, so you're going to go more medial or in the middle or mid-medial? What is your strategy here?
Maybe just immediately a hair medial to A2P2.
So you're going to go mid-medial.
Exactly, just medial to A2P2, and I would confirm what I see on 3D on 2D imaging, where I would have higher frame rates and higher resolution.
Okay, final commentary. Do you think you're going to end up with one device or two devices?
Just initially, I would try to get this with one device.
With one device.
Yeah.
And final, Dr. Jamila, your comment before Dr. Zakaria tell us what is going to be his plan.
I think just a quick question to Dr. Anas. Looking at the jet from the 3D perspective, it's looked like more lateral. So can you explain having your imaging focusing on the medial aspect? I didn't really get that clearly. I think everyone would agree the jet is more on the lateral side.
Well, I would confirm that on 2D. I wonder if the 3D images are slightly deviated, or they're slightly on the side. I can't. The color 3D may not be definitive when it comes to whether lateral or medial. And I'm afraid in this case. So if this was a real life case, what I would do is I would go back to 2D. I would do the bicommissural view And then we try to kind of understand whether this is mostly medial or lateral. If you can see on the top, if you actually see on the top left image, you can see that the jet is really coming.
Could we have the slides up again?
Yeah.
So I think Dr. Anas is mentioning very important point is
Yeah.
having our basic view to analyze really the anatomy and the location of the origin of the jet. So the bicommissural view is very important. Using X-plane or multiplanar imaging will also support and help. And the long axis view.
Yeah. So great. So we're back to the slide. So if you can actually, the top left image, you can see that the jet is quite wide. It's actually coming from the entire commissural line, and the line here is cutting lateral to A2, P2 on the top left image. And you can see on the AP view that the MR is really not that prominent. If I had to guess, like I wonder if someone actually explained slightly medial to this, that the jet is probably centered to medial.
So Dr. Anas, like to go on, like your aim is going Abbott, NTW.
NTW.
And you consider a mid-medial approach
yes.
and then evaluate the situation and go with it.
That's what I would do.
Okay, so this is your plan. Let's see, Dr. Zakaria, what do you think? Are you going to agree with him or are you going to disagree with him?
If you go back to the 3D, something which I really didn't notice in the beginning, but there is a relative prolapse of the anterior mitral valve leaflet in the A2, if you can see it. It is in here exactly. But there is also another prolapse in the posterior leaflet, which is here. So it looks for me, it's a combined anatomy where you have a relative prolapse of the anterior mitral valve leaflet, A2, but also there is a prolapse in the posterior mitral valve leaflet, which doesn't go with the functional completely. So it might be also, although this prolapse is small in the posterior leaflet. If I have, sorry. I would say the A2 is a pseudoprolapse because there is, in this area, exactly, there is a restriction of the posterior mitral valve leaflet and it's causing the pseudoprolapse. But in the posterior, in this area, I think it's a true prolapse. Now, if I have the Pascal with me in the lab, I will start with probably B10 because it is wider and it can take a whole anatomy.
So you're going to use the implant with a spacer to overcome like a couple of stuff. Number one is the restriction of having multiple devices due to the area. Number two, having a spacer and a wide jet that will help you around.
Exactly.
So you're going to go with a spacer or an implant with a spacer, which is a P10 in a Pascal Edward Life Science. Where are you going to position it? So we have like
probably
a couple of stuff.
I will go with in the middle and take everything together. But the alternative approach is to take two A's and put one here exactly and another device just beside it to take the both pathology.
Okay, so you just show us like, you know, and the one is not suitable. Do you think 3.6, 3.8 area will tolerate two aces?
It is a borderline, let's say, area. And still, I think I will try it with two aces.
But your first choice, I'm in the lab, I'm with you. You're going to tell me open an ace or P10?
You know what's the problem with the B10? B10, because of the shape of the device, it doesn't allow you to put two devices beside each other. So to tell you the truth, I prefer the ace to start.
So you're going to go with an ace to have more controllable situation, and you're going to go in the middle A2, P2. Two questions to both of you. What is your acceptable gradient, Dr. Zakaria? What is your acceptable gradient before I will deploy your NTW, before I deploy your ACE? Dr. Zakaria.
Up to 5 is acceptable.
You're going to accept 5. Dr. Anas.
So post-procedure is going to go up by 2 points. So I wouldn't take anything more than 6 is my limit.
6.
Yeah.
Are you going to depend only on your gradient, or are you going to ask me, or Dr. Ahmed from the side, what is your LA pressure? Are you going to ask him, or you just think, nobody cares about what he's saying? Are you going to do something extra by image-wise?
Sure. Yeah, I would definitely look at the pulmonary. Yeah, I would definitely look at the pulmonary veins at baseline for sure, and then I would look at a response post, because to me, like, this is kind of the most predictable, the feature which I can use to predict patient clinical response, essentially.
Okay, so your number is 6, your number is 5. If it's more, you're going to tell me out?
Control the heart rate.
Yeah.
Okay, so Ahmed, tell us what happened, because something happened for sure.
Thank you very much, everyone. I think this is the downside of having too many cardiographers in one room, too many aspects. So let's go back from desperation to delasting mitral clip solution. So let's go to the procedure itself. So this is the bicaval puncture. You can appreciate that in here that this is you can see the tenting, and then from the short axis, this is the aorta. So this is the short axis, proper one, and this is the needle. You can appreciate that there is a needle in here, and then you measure this is the still image, and you can measure from the tip of the needle to the mitral valve to know that you're in a good shape, and this is an acceptable height, and 3.4. So, and then we advance the sheath, and then you can appreciate here the heart rate is 162. So at the time, first the clinical dilemma, we kept whatever went in there. We turned back to the echocardiogram and echocardiographers, and we asked them what's going on. Can you allocate the tip of the needle or the catheter? Is it in the left atrium still? And is there an pericardial effusion or not? And apparently it was just because the patient has an atrial tachycardia, we tackled the wall of the left atrium. And it was anesthesiologist took care of that, and the heart rate went to 80s to 90s. So that is one clinical point. So do not pull anything out, just investigate and find out what's going on. And that is an important. And then...
So can we identify, let's just a quick question. Play the video, please. We don't know so far what device did you use. So could you play it for us? No, the 3D. Good. The 3D. It's okay.
The 3D?
Yeah, that one, the next, that you show. Play it, please.
Go ahead.
So Dr. Zakaria and Dr. Anas, and all the images, what do you think this device is? Can you identify it? Is it an Abbott or is it an Edward? Is it Pascal or is it...
Yeah, I think this looks to me like just subjectively, this is like an Abbott device, the way it
Zakaria,
looks.
what do you think? Abbott? Dr. Ahmed, Dr. Jamila? Abbott?
You put your mind on that.
Okay. So, is it an Abbott or is it not?
It's a mitral clip,
It's an Abbott.
G4
Okay.
XT.
XT.
Yes.
XDR?
Okay, again, back to Dr. Anas.
Is it
You
XDR?
were telling us you want an NTW. It's an XT. You agree or disagree?
It's not the W one.
It's XT only. Do you
It's
agree?
XDR.
Yeah.
No.
We have a wide jet. I generally go with the W, with a wider jet, but we could, it's a bit difficult to
It's
guess
not
what's
your
gonna
choice, but it
not
is
my
what
first
it
choice,
is.
but I'm not sure, it's not an absolute no. We can see what happens, I
So,
guess.
Dr. Zakaria, it's not what you said, but do you agree with his choice of having an XT? What about Dr. Mukhari? What do you think? You would have agreed with him, or you should fight him on the table? No, no, no.
No, I will prefer with XTW.
XTW, going for the jugular.
XT.
Dr. Ahmed, what do you think?
But let's see what's the result. Yeah.
Right or wrong? You want a smaller clip or a bigger clip?
So here, even after we open the side of the jet, I'll go to a narrower jet, a narrower clip.
You want to go with a narrow. Okay, so
A taller jet, but narrower. I mean, XT regular.
XTR. This is an XTR.
That is
Okay.
the one that we used.
So your aim was exactly mid-lateral?
Yes.
Okay.
Okay, so, and this is the first grasp, first attempt. You can see that the mitral regurgitation
I will pause
is
you
better.
here.
But look
So
at the
against-
gradient, echo.
So against both of our imager recommendation, as usual, the interventionist decided something else. What are you going to tell him, Dr. Anas, at this stage? This is after the first. You have a good MR reduction, but this is your gradient. It's about 9.
Yeah.
At the heart rate of what? Heart rate of what? What is the heart?
95.
In 90. So what
Yeah.
are you going to tell him at this stage, Dr. Anas?
To me,
Take it out.
number one, I would, just as a few technical tips, I would just make sure, double check whether the patient is on inotropes, something that would elevate your gradient. But generally, assuming that this is an accurate assessment, the next day, you would expect the patient to wake up with a gradient of 12, 13, something like that. So I wouldn't take this as a result. I would deem this to be not acceptable and to move over to a smaller device.
Dr. Zakaria, so check the patient, check the anesthesia, check the surrounding. What are you going to check next?
And I would check the perpendicularity because
think we're distorting the
always, if you have higher than expected gradient, look for distortion of the valve.
Okay. So I think we're
Isn't
in
it
the
that
same
the-
manual.
if the
What do you
valve
think,
is-
Dr. Ahmed?
If the valve is distorted, the mitral regurgitation will not regress to that extent. He will have create a jet somewhere else.
Yeah, an eccentric jet, yes. I agree with that.
So,
So
you have,
in this situation,
Yes,
just
Dr.
add,
Ahmed.
I would be a bit concerned how much we grasp from the both leaflet, like and we are putting a lot of tension on the leaflet to grab the annulus to bring it together. So I would do like going back and look at my baseline leaflet length and go back and see the leaflet that we grasp, like how much the difference, then try to re-grasp again.
okay.
Okay,
Tell me
that's
that you
cool.
did something after this.
Well, we called anesthesia and they told
You
us
did
that
something
please-
or you deployed?
No, we did not deploy that. So we try to go
They're
and
still
try
with
to
me,
find
yes.
another. And this is the second attempt. We open it and we just show the.
So what is the difference
perpendicularity.
between the first grab and the second grasp? We can see, okay, there is some MR going from the medial, so most likely you went a bit lateral or something, yeah.
Yeah.
So
And
maybe
3D
Dr. Anas,
images?
you were right
So
from the
what was
beginning to
done
go a bit
exactly?
lateral.
To get it straight, what was done? The gradient came from
Any
9
3D images to understand the movement that's
to 5.
happened
What's
between the
exact-
first and the second attempt.
The heart rate is also dropped significantly.
Yeah.
That is true.
So a couple of stuff happened. They controlled the patient. They moved the clip. So you agree that there was no distortion of the valve.
No.
Our perpendicularity was excellent.
That's what's
You just
sure.
moved more laterally.
That's true.
So point to Dr. Anas about the positioning of the clip. But there was still like a jet on the medial. Did you do something? What was the consensus at this time?
So we said that if we can just go a little bit to that jet in order to get some of it, and the gradient is 5, so the mean gradient is 5. So, and we try to go. Now we shifted from going from the lateral going lateral to the other opposite side, and you can see that the clip or the regurg is better,
Yes.
and the
Yeah.
gradient is better too.
So now instead of going more lateral, you went a bit
So,
more,
yeah,
sorry,
so-
more
so-
lateral you went.
So we took it out, assure the perpendicularity, and we try to grasp another side. So maybe the idea or the hypothesis of the distortion of the leaflet or the tension that was kept in the leaflet, that's what causes the valve or the annulus to be opened from a side.
Professor McKenzie, any thoughts? What do you think so far? You have a stern interventionist in the room. He's like going against everything.
Yeah.
So we
What are you
did
going to tell
something.
him?
So we did something. It's good, but we cannot explain it. That's what.
Yeah, I would say it's not a final result because you're still attached to the device, and we know for the newer generation it's a very stiff device. So the prediction of what's going to happen when you deploy is not clear. So I would keep that in mind. I think I would agree with some of the initial comments that a smaller, shorter arm device would have been appropriate for the functional nature of this MR. And I was curious what your imager suggested at the beginning of the case in your own institution.
Did you have a fight with him?
Yeah, it's between the NTW and the XT, and then we rule of the dice,
pushed
and
for
then
an
it was
XT.
for an XT.
What made you go lateral? Sorry, what was the thought process that made you go more lateral? Like in the cath lab, like you have more jet medially after you moved a bit lateral. So what made you go even further lateral?
That's something in the interventional cardiology that it's like a gut feeling that you don't know how to say to explain it, but you just tried it because you got stuck.
Possible there was an indentation or as Zakaria mentioned, in the anterior there were some changes there, but maybe they were
More
grasping
degenerative changes.
at A2 something that causing this tension, and the moment you let away and moved medial, you had everything.
Even that we assure that we release the tension and we push the clip a little bit into the LV, but still that,
Okay. So
I think one more comment on that. I think sometimes we may be unaware of a nuance of a rotational change that makes all the difference, especially with the large clip.
Yeah.
And that may happen by circumstance or by, by intuition or something, but a slight orientation change in such a big jet may make all the difference. And I would agree that some of the initial images, also the 3D on FUS with the color, suggested that maybe lateral is where the bulk of the jet originated, although I agree it was a broad jet to begin with.
So did you deploy this one, or still you had reservation?
We did.
So I'm
Okay.
just going to
After
add for the 3D, mirroring the other comment, about the 3D of the jet. The jet sometimes goes from some side or like a different location, but it goes like this. So widening the jet, sometimes it goes on the side, becomes more eccentric. So what we do, we go with the dual view. If you have your images, tell him go to dual view. Dual view shows you the image from below, from the ventricle. Then you go down with the filter, wall filter. I'm sure that you know. The wall filter tells you narrowing all the maximum velocity of the jet to the center of that wide jet. So you can now focus on your focus from below, from the ventricle, without looking at the width of the jet. So you're more less biased from where it's going. You know, sometimes going this way and you're looking from above. So sometimes actually the site is here, it's not there. So look at it from below, it's very helpful.
That's a very good point.
More recently, I start to use the wall filter for the 3D color to look for and I found it's very helpful in deciding the exact origin of the jet.
So,
nice. Okay,
deployment,
so we did
the gradient and what is the
gradient
MR?
was 4 to 5, and that even it was sustained in the TE post. And then the heart transplant team, they asked us to implant the cardiomems, and we did that too. So 3 months after the MTR, patient shows an improvement of her symptom profile. Patient shows an improvement of her exercise capacity. This is the numbers of the cardiomems that has been obtained from the patient, and you can. This is the systolic pulmonary pressure, diastolic, which is a surrogate of the wedge pressure, or the LVDP, if you want to say that. And this is what is the 0 and -1 is the target diastolic pressure that you wish for, and you can appreciate that this patient, despite of few spouts in here and there, but she was maintaining with the near normal or just mild increase of pulmonary diastolic pressure. And that tells you that she is improving from hemodynamics point of view too. VO2 max pre-MTR, 6.8. The VO2 max after 3 months after that, 19. So the heart transplant group verdict that the patient is out from the transplant list due to the clinical improvement.
Punish them because they're good now. Okay.
So if let me talk a little bit about this. This is the mitral clip as a bridge of the heart transplant, and that was published in 2020. And this is the demographics of the patient, and you can and this is our patient on the right side, and it matches some of the demographics that it was tested, and you can appreciate. And I know that you know about it, but it's 27% out of 119 that has been studied. They were out, or it was taken out of the list because of clinical improvement, and that our patient is one of them from in our side. I want to speak about is it okay to accept a higher gradient, and that is an article that was published in JACC 2021 by Halaby et al. And it's about the effect of the mitral valve gradient after mitral clip on outcome of secondary mitral regurgitation. And on these patients with symptomatic mitral regurgitation, higher mean gradient on discharge did not adversely affect the clinical outcome following mitral clip. And if we go through the numbers, they categorize the patient to quartiles based on their mean gradient, 2.1 and one quartile, and then there's a 3, and then 4.2, which is our patient in that range, and the extreme ones with the 7.2. And you can see in the Kaplan-Meier curve that they all match, and there is no difference, clinical difference between them. 7 is a bit of a stretch, but at least a 5 or 4.
Okay, keeping that in consideration, that the area, this is all functional MR, and all these patients' area were a bit 4 and above. So don't take that in an area with 3 and then you say, yes, this is acceptable.
That is a very important, because there is another article that in the same week, in 2021, that was published, it shows that for the degenerative MR, higher gradient is definitely an independent prognostic factor, but not in functional MR. We don't know about the mixed type. If the idea of a hypothesis of Dr. Zakaria is true, that there is some of prolapse in the mid of the A2B2, but or the anterior leaflet, I mean. But at least we know that from functional mitral gradient, mean gradient does not, it's not a bad thing. And I just will finish on this. All-cause mortality, cardiovascular mortality, and heart failure hospitalization, all of them in that quartiles are matching and they are the same. And by this, I thank you all.
Thank you, Dr. Ahmed.